Welcome to another session of Dentistry and more. Today's topic will be continuation of the question paper discussion on oral medicine and radiology. So the topics that will be discussed are developmental disturbances, then followed by bacterial, viral and fungal infection, then the orofacial pain. So under the topic of developmental disturbances, the short notes that can be asked is glossitis. Itis, as it means inflammation. So the inflammation of the tongue is considered to be the glossitis. And one of the few manifestations that can be seen under the glossitis is caused due to anemia. So it can be considered as an anemic glossitis. Then followed by the another condition, that is a median rhomboid glossitis, that is seen. You can discuss about what is it. Median rhomboid glossitis is a candida associated lesion which is found to be an erythematous lesion that is seen especially on the midline or the center part of the posterior aspect of the dorsum of the tongue, which is caused by candida hyphae. So it can be associated along with smokers, denture wearers, as well as steroid inhalation used patients. And then next is the benign migratory glossitis, which is the other name for geographic tongue. The geographic tongue, as it is called, because it depicts the geographical map areas around the tongue portion itself. You can see that it is found to be affected around the lateral borders of the tongue as well as the dorsum part of the tongue. So that highlights about the glossitis. Next is the question asked about the developmental anomalies of the tongue or the developmental abnormalities of the tongue. So you can enlist the developmental abnormalities such as that has been enlisted over here: aglossia, microglossia syndrome, macroglossia, ankyloglossia, cleft tongue, fissured tongue, median rhomboid glossitis, geographic tongue, hairy tongue, lingual varices, as well as lingual thyroid nodule. So you can each explain what, at least two liners to explain what is that condition as well as where is it been associated with or what is the etiology behind it. So as you know, fissured tongue, it can be considered as long fissures or deep grooves that are seen within the dorsal part of the tongue. And then the hairy tongue, which is found to be an elongated elongation of the filiform papillae, wherein it leads to collection of microbes as well as accumulation of food debris within the grooves itself of the elongated filiform papillae. So it leads to this staining, or the black stains are seen due to that, and that's why it's called as a hairy tongue. And then you have the ankyloglossia, wherein you see that the lingual phrenum is found to be attached towards the tip of the tongue. So due to that, it leads to treatment plan is nothing other than the lingual phrenectomy, and then followed by geographic tongue, which have been explained in the previous slide itself. Next question to be asked is a macroglossia. As the name suggests, macro meaning it's an enlarged tongue. So it's considered to be a developmental anomaly wherein it is associated with certain syndromes such as that of Down syndrome, Beckwith-Wiedemann syndrome, and the etiology can be it's caused due to the dilation of the lymphatics, or it can be caused due to the muscular hypertrophy or the inflammation of the muscular region. And then you can see that it is found to be associated with the true or the pseudo retrognathia, and the treatment is nothing other than a reduced tongue size by going through a partial glossectomy. So the macroglossia, sometimes you can see that due to the enlarged tongue, you can see the tooth indentations that are seen around the lateral borders of the tongue, especially around the lateral borders as well as in the tip of the tongue. And then you can see that sometimes you can see there is an absence of all the papillae itself. Next is moving on to the next topic is the bacterial, viral and fungal infections. The shortages that can be asked under this topic is the old manifestations of HIV. That's a frequently asked question, and in that you can go through the classification or the groups that has been allotted. That is 3 groups, wherein you can speak about the group 1. Lesions are strongly associated with the HIV infection, which has been enlisted here, followed by group 2, that is the lesions less commonly associated with HIV infection, and group 3, which is lesions that are seen in the HIV infection. So if you enlist these 3 groups, you can fetch more marks for this question. So the next question that can be asked is a laboratory diagnosis of HIV. So you can divide into 2 tests, that is the screening test as well as the supplemental test. Under the screening test, you have the ELISA rapid reagent test, and then in the supplemental test, you have the Western blot test, and then the indirect immunofluorescence and the radioimmunoprecipitation test. So if you want to describe about it in detail, you can go through the textbook of microbiology itself in Anand Narayan. It has been elaborated about each of these tests. And if in case you want to highlight more about the immunofluorescence test, it's also given in the textbook of oral and maxillofacial pathology by Neville. So in that they have given a pictorial representation of how to go about for immunofluorescence, that is the direct and the indirect immunofluorescence. You can go through that. In order to elaborate about the immunofluorescence itself, you can go through the textbook of oral and maxillofacial pathology by Neville, wherein they have given a pictorial representation of how is the direct as well as the indirect immunofluorescence. You can go through that textbook. Next, moving on to the short notes. Actinomycosis. Actinomycosis is found to be affecting the cervicofacial region, most commonly seen, and then followed by the abdomen and then the respiratory system, such as that of the lung, as well as the peripheral skin has been involved. So the actinomycosis is found to be caused by Actinomyces israeli, and the etiology can be caused due to any history of trauma, as such as that of tooth extraction or to the blow to the jaw. Then also swelling can be seen. That is a clinical manifestation that can be seen, as the swelling is quite common and is found to be either localized or diffuse, and if they are left untreated, it can lead to progression for the discharging sinuses, and in these sinuses you can see the yellowish sulfur granules. If a fluctuant abscess is noticed, you can go for an aspiration or drainage, followed by an excisional biopsy for that can be performed, and then you can go for a histopath reporting. So these are the types that are seen in the actinomycosis. That is, most common is found to be cervicofacial, and then followed by the thoracic, and then the abdominal and the pelvic actinomycosis. Next question, as I said already, this question has been discussed. There's the oral manifestations of HIV. You have to enlist the 3 groups, that is a group 1, 2 and 3, and then you have to enlist under each group and cite in examples for what all are the diseases or the conditions that can be seen under each group. Next is the question that even I have discussed this question in the previous session. That is, one of the favorite questions to be asked is about the antifungal drugs. If specifically asked about topical antifungal drugs, you can go through the Burkitt's textbook, that is Burkitt's oral medicine textbook in the 11th edition itself. They have given this tabulated form, that is the topical antifungal drugs that are seen for managing the management of oral candidiasis cases. So they have enlisted 3 topical applicants, that is the nystatin, clotrimazole as well as the ketoconazole. In that, what are the indications they have mentioned, even the administration, what kind of mode of administration has been used, and then the dosage, and what are the contraindications. All these can be highlighted, and if you can put it in a tabulated form, well sufficient enough for answering the question. Moving on to the next topic, that is the orofacial pain. So the long issues that can be asked is to classify the orofacial pain and then describe in detail the etiology, clinical features, investigations and management of trigeminal neuralgia. So once you start a question for answering about orofacial pain, it's always best to define orofacial pain as given by IASP. That is the subject's conscious perception of modulated nociceptive impulses that generate an unpleasant sensory and emotional experience associated with the actual damage or described in terms of such damage. So then, after giving the definition of orofacial pain, then you can go through the classification that is being given in Bell's classification in the year 1989. So this is how it is being classified, that is axis 1 and the axis 2. In the axis 1 you have the physical conditions, under that you have the somatic as well as the neuropathic pain, and they have explained about what kind of subtypes of the somatic pain and the neuropathic pain. Then coming on to the axis 2, that is the psychological conditions, you have 4 variants such as the mood disorders, anxiety disorders and the somatoform disorders and other variants. Then the second classification that you can go through, it's given in Ravikiran Ongole itself, and that they have classified into 5 types, that is the intracranial structures, then the extracranial structures, then the musculoskeletal disorders, neurovascular disorders, then the neurological disorders. So under that, the intracranial structures, which are the structures that have been involved, then the extracranial, again what are the structures involved, then followed by musculoskeletal disorders, that is wholesome of TMJ disorders, that is the masticatory muscle disorders, and the fibromyalgia, followed by the cervical disorders and the generalized polyarthritis. Then you have the neurovascular disorders such as that of migraine or the cluster migraine headaches, cluster headaches. Then you have the tension type of headaches and the cranial arthritis. Under the neurological disorders, you have the paroxysmal neuralgias as well as the continuous neuralgias. In the paroxysmal, you have the subtypes, that is the trigeminal neuralgia. Then you have the glossopharyngeal neuralgia. In the continuous, you have atypical odontalgia, traumatic neuroma. Moving on to the sub-question of the trigeminal neuralgia. First, when you speak about the etiology, we have to speak about the two types, that is the classic and the symptomatic type. In the classic trigeminal neuralgia, it is found to be not associated with any underlying neurological disease, whereas the symptomatic is found to be associated with the neurological disorder. And also in the classic trigeminal neuralgia, it is associated with the tumor of the cerebellopontine angle as well as a vascular malformation. Even the meningioma of the posterior cranial fossa is also found to be associated with the atherosclerotic blood vessel along with the superior cerebellar artery. Now moving on to the clinical features, we have to speak about the red highlighted ones which I mentioned over here. That is the how is the pain characteristic. That is, there is episodes of intense shooting, stabbing pain, and that lasts for a few seconds and then later it disappears. And sometimes you can find that another characteristic of the pain is the electric shock like quality as well as it's a unilateral. Out of the three branches that have been located from the trigeminal nerve, it is found to be the maxillary branch that is found to be commonly been affected. The trigger zone is found to be an area of the body wherein there is a specific type of stimulation that triggers a specific type of response. So that is with the trigger zone, and most of the trigger zones that have been affected is found to be the nasolabial fold, then the corner of the lip, and also it is found to be when associated when the patient undergoes shaving, showering or eating while speaking, or even in case of when there is any exposure of wind. Speaking about the three branches of the trigeminal nerve, we have the ophthalmic branch, then the maxillary branch, then the mandibular branch. So that is assigned with V1, V2 and V3 respectively. So that is V1, the ophthalmic nerve. It supplies towards the scalp as well as the forehead and the upper eyelid. And whereas the V2, that is a maxillary nerve, it is found to be associated with all the lower eyelid region as well as the cheek, nares and the upper lip. Whereas the mandibular nerve, that is a V3, it carries the sensory information towards the lower lip, the lower teeth as well as the gums and the chin and the menton region and all. So out of these three branches, it is the maxillary branch which is found to be most commonly affected. Now when we undergo investigation, we have to go through MRI scans of the brain so as to detect any extracranial or the intracranial tumors or any vascular anomalies. And in case of while taking the OPG or the panoramic radiograph, we find the status of how the calcification of the styloid process is. So in the treatment plan or the management of trigeminal neuralgia, this table has been taken from Ravikiran Ongol again. So it's better always to make a tabulated form or a flow chart as to how to manage the trigeminal neuralgia cases. So this is how it has been listed down in regard to the treatment of trigeminal neuralgia. Sometimes they can ask even for short essay how to manage trigeminal neuralgia. So this flow chart elaborates about how to go about through the treatment. Next is about the question is about the definition of pain, again the frequently asked question, and then followed by the classification of or the causes of orofacial pain, then discuss the differential diagnosis of the chronic unilateral facial pain. So sometimes they can ask just separately the short essay itself that discuss the differential diagnosis of chronic unilateral facial pain. I will be discussing about that later slide. As of first itself, I have mentioned earlier, you have to give the IASP definition of pain. That is a subject's conscious perception of modulated nociceptive impulses that generate an unpleasant sensory and emotional experience associated with actual damage or described in terms of such damage. That is the definition that you should go about for orofacial pain, followed by the classification, that's the Bell's classification that's given in the 1989 that I have already previously discussed. Now, moving on to the differential diagnosis of chronic unilateral pain. When such a question is being asked, we have to enlist these other ones for the unilateral continuous, as well as the other type is a unilateral episodic orofacial pain. Once the question of unilateral continuous orofacial pain is given, this is the list of the conditions or diseases or the referred pains that you have observed in the unilateral continuous orofacial pain. Once you're speaking about the episodic orofacial pain, these are the enlisted ones, that is all the trigeminal neuralgia, glossopharyngeal neuralgia, all comes under the unilateral episodic kind of orofacial pain. Now the next question asked for the trigeminal neuralgia as short essays itself. As how I've mentioned in the long essay question, you can go about with the etiopathogenesis, then you can speak about the clinical features, followed by the investigation and the management of trigeminal neuralgia to fetch in your full marks for your short essay questions. The next frequent asked question is about the myofascial pain dysfunction syndrome. So once this question has been asked, you can come under the TMJ chapter itself. Even in there also, in Ravikir and Ongol, they have given beautifully the description of how to go about the myofascial pain dysfunction syndrome when asked. So once they ask this question, you can just mention about the symptom complex, as well as it has been associated with the facial head pain as well as a TMJ dysfunction. It arises from the skeletal muscle, which is involving the head and neck, as well as the lower back and the shoulders. And there are trigger points also for this myofascial pain dysfunction syndrome. There is also referred pain zones, and the muscle pains also arise from the taut bands with the trigger points or the tender spots. So the predisposing factors that are seen in the case of myofascial pain dysfunction syndrome is the acute muscular injury. So this is a pictorial representation as how the contraction knots have been formed within the skeletal muscle fibers itself. And the clinical features that are seen in myofascial pain dysfunction syndrome is the unilateral dull pain that is most commonly seen around the preauricular region, and it worsens while awakening. And then there is tenderness of the muscles of mastication, and that is on palpation, and there is also limitation or deviation of the mandible while opening the mouth. So when you're speaking about the management part, we have to go about this following enlisted points for you that is mentioned. That is counseling the patient, then followed by the physiotherapy, and then you go about the TENS therapy, that is the transcutaneous electric nerve stimulations that are given. That's how the pictorial representation is about TENS therapy that has been done. And then you can describe about TENS and all other the management perspective of myofascial pain dysfunction syndrome. It is already elaborated in the chapter in TMJ disorders itself in Ravikir and Ongol textbook. So you can have a read about it through that. Now speaking about the short notes, the question frequently asked is the medical treatment of trigeminal neuralgia. So again, you can refer the textbook of oral medicine by Ravikir and Ongol itself. They have given the flowchart beautifully depicting how to manage trigeminal neuralgia cases. So you can list out the drugs that have been used for managing trigeminal neuralgia, such as that of carbamazepine, and then followed by the second line of drugs, that is a lamotrigine, then the baclofen and pumozide. What is the dosage that has been given, and for 1 day how much is the dosage that has been given. All that has been enlisted over here, so you have a read about it. Then last but not the least, about the Ramsay Hunt syndrome. So that is one question that has been asked as short notes itself, and you can answer by stating that it is also associated with the herpes zoster infection of the geniculate ganglia, and the nerves involved are the facial and the auditory nerves. The clinical features that you see, because it's facial nerve, facial nerve has been involved in this, so you can say that there is facial paralysis that has been noticed, and also there is pain, vesicles in the external auditory canal, as well as the pinna of the ear and the oral cavity. There is tinnitus, there is vertigo, and also ipsilateral hearing loss. And the investigations that you go about for Ramsay Hunt syndrome is by cytological smears for checking from the vesicles, and also you can go for a polymerase chain reaction, that is PCR test, followed by the direct immunofluorescence assay. And by managing for these cases, because it's already a viral related disease, or a viral related syndrome, so you can give an antiviral drug such as that of acyclovir, valacyclovir, and also famiciclovir. So the next session will be continuing with the same question paper discussion with their other topics. Thank you for your patient listening. Good day.